Dr. Najah Rashid Al-Zayani, Vice Chairman, Bahrain Specialist Hospital. Professor Igor Aznorian, Head of Crystal Vision Eye Clinics. Dr. Qasim Arrati, Managing Director, Bahrain Specialist Hospital. Mr. Onik Aznorian, Managing Partner of Crystal Vision Group of Companies. Esteemed guests, participants, ladies and gentlemen, good evening. It is with great pleasure that I welcome you to the CME event about optimizing clinical practice in ophthalmology, presented by Bahrain Specialist Hospital and Crystal Vision Pediatric and Adult Eye Clinic by Professor Igor Aznorian. Now, ladies and gentlemen, please join me in welcoming our distinguished speaker for today's welcome address. She is the Vice Chairman of Bahrain Specialist Hospital and is a renowned consultant in gastroenterology and internal medicine. Additionally, she holds the esteemed position of chairperson for today's event. With her vast experience and expertise, we are honored to have Dr. Najah Rashid Al-Zayani to lead us in inaugurating this event. Let's give her a warm welcome of applause.
Good evening, colleagues and friends. It's my great pleasure to welcome you all to the CME. Learning about eye diseases is far-fetched from my specialty, but I'm very proud to see world experts joining us at the Bahrain Specialist Hospital and raising the bar of healthcare, especially in ophthalmology and specifically in pediatric ophthalmology. We are more than happy to join hands in giving the best care for our pediatric and adult patients in the field of eye diseases. I look at Bahrain Specialist Hospital as a boutique collection of specialists from all over the world, and I welcome expertise from different parts of the world to give the best care that can be delivered to patients. This is a very special place in my heart to see people from different parts of the world delivering their expertise and working together in harmony to give the best medical care to patients. I welcome you all and wish you success, and I hope to see many more groups of world experts joining us under the roof of Bahrain Specialist Hospital. My gratitude is to Dr. Qasim Ardati and to my son Majid Ardati, who worked very hard to make this project a reality. Without their effort, I would not be able to achieve this aim. Thank you all, and hope you have a very fruitful meeting today, and hope to see the best results for our patients in the future.
Thank you so much, Dr. Najah. Crystal Vision Eye Clinics is under the visionary leadership of the two brothers, Professor Igor Aznorian, Head of Crystal Vision Eye Clinics, and Mr. Onik Aznorian, Managing Partner of Crystal Vision Group of Companies. This partnership signifies a significant milestone in introducing a cutting-edge ophthalmological technologies from Russia to the Kingdom of Bahrain. The decision to establish a clinic in the Middle East reflects a long-standing aspiration realized through collaboration with the esteemed professionals of Bahrain Specialist Hospital. Ladies and gentlemen, let's take a moment to witness the remarkable collaboration between Bahrain Specialist Hospital and Crystal Vision Pediatric and Adult Eye Clinic.
Welcome to the Crystal Vision Eye Clinic in Bahrain, which is comfortably situated in one of the best hospitals in the Gulf countries, Bahrain Specialists Hospital, the first JCI licensed hospital in the Kingdom of Bahrain. Crystal Vision Eye Clinic in Bahrain is a bright successor of Russian Crystal Vision Eye Clinics by Professor Igor Aznorian. There are 10 Crystal Vision Eye Clinics operating in Russia, mainly located in the city of Moscow. Let us introduce the central head clinic of Crystal Vision in Moscow. The clinic is located in the very center of the city in a 4-story ancient building that is more than 100 years old. The history of Crystal Vision Eye Clinics began on June 4, 2001.
Dear friends, dear colleagues, Crystal Vision is an ophthalmological clinic system that has many years of experience, already 22 years of experience, working as a non-state medical institution in Russia. 22 years ago, we started our activity with one clinic and were able to create a unique system that has centralized management, which has unified standards that meet all the highest criteria of international requirement.
Dr. Igor Aznorian, Professor, Ophthalmic Surgeon, formulated the basic principles of Crystal Vision Eye Clinics. Its own treatment standards based on international protocols. Synergy of scientific, clinical, and educational activities based on the principle of university clinics.
Our company, Crystal Vision, is a member of the International Council of Ophthalmology, a unique combination of extensive clinical experience, a significant amount of teaching activity, wide missionary work, and other factors has created the foundation that has made Crystal Vision a well-known company, not only in the region, but also in many countries around the world.
Bahrain Specialist Hospital is a highly specialized medical center that provides up-to-date medical services by experienced consultants and specialists, using the latest technologies with the state-of-the-art medical equipment and system. It is the market leader with respect to the complexity of care being delivered across multiple specialties in the private sector for over 20 years.
At Bahrain Specialist Hospital, we take pride in associating with experts in different fields. We are providing ultimate care in lots of specialties, and we are very proud for the association between our hospital and the group from Russia, Crystal Vision. I believe that this is a combination that will serve the community, and it will be a reflection of the importance of providing the best of services, not only in eye care, but in all other parts of the hospital. We have had associations with experts in other fields like the cardiology, but we are very happy to associate with this excellent group from Russia in providing the best of care for adults and pediatric eye problems. Thank you very much.
In Crystal Vision Eye Clinic, we use the most advanced technologies in the treatment of eye pathologies and for surgeries, as well as our own unique innovations developments in the field of diagnosis, treatment, and surgery. Our clinics and operating theaters are equipped with high-end facilities. We are honorable members of the top worldwide ophthalmological associations, and we incorporate the most up-to-date international advancements in ophthalmology into our activities.
Jason Yan from Hong Kong. It gives me my great pleasure to give the best wishes and congratulations to Professor Igor and his team for the grand opening of the Crystal Vision Eye Clinic, April in Bahrain. I am very sure the team will continue the excellent work to provide excellent caring service to various populations, from adult and age population to children, for their better vision and a bright future.
Crystal Vision carries a substantial mission. The mission is to spread the technologies we possess, all the best practices we have brought from around the world, and our own unique developments, to disseminate all of this among ophthalmologists from different countries, ensuring widespread adoption and knowledge sharing. When opting for Bahrain as the location for our operations, we were guided by the fact that this extraordinary country, a one-of-a-kind and breathtaking country, has chosen the path of intensive development in the present day.
Crystal Vision has been invited to be a member in the International Pediatric Ophthalmology and Strabismus Council, the one and only global structure that defines vectors of the development and research in the field of pediatric ophthalmology and strabismology.
I would like to congratulate Dr. Igor Aznarian and his team for the opening of the Crystal Vision Clinic in Bahrain. We have known Dr. Igor for the last 25 years, and we trust that his team will provide the highest quality of eye care for all. Thank you.
Crystal Vision doctors are members of American Association of Pediatric Ophthalmology and Strabismus, International Strabismological Association, European Pediatric Ophthalmology Society, European Strabismological Association.
Dear Igor, first of all, congratulations on the new clinic, and for the Bahraini people, you're lucky to have Igor and his team to be there as bringing you the world-class ophthalmology clinic. And again, congratulations to everyone, and hope to visit you soon enough. Take care.
I am Giovanni Battista Marcone. I'm a strabismologist in Italy. I'm actually secretary of the European Strabismological Association and also IPOSC, International Pediatric Ophthalmology Strabismus Council. I would like to, I know Professor Aznarian since many years, and I would like to congratulate with him for the idea of opening a clinic in Bahrain, and also for the intense friendship and scientific collaboration we have started since many years. I will be happy to go to Bahrain if possible to join him and see this new adventure of Professor Aznarian. So thank you very much for the friendship.
Crystal Vision, together with Bahrain Specialists Hospital, opens its doors in the Kingdom of Bahrain and shares its experience, contemporary eye treatment technologies, and highly professional expertise of children and adults in the area suffering from different complicated eye pathologies.
Our partners, Bahrain Specialist Hospitals, are without a doubt the absolute best thing we could have hoped for and expected when we made the decision to bring our capabilities to Bahrain, and we are incredibly grateful for their invaluable support and collaboration. And I have to give a big shout out to all the people we have been working with throughout this entire time period. I am extremely grateful for their collaboration and support. Friends, thank you very much for your attention, and I have high hopes for our collective success.
It is now my honor to introduce a distinguished figure in the field of ophthalmology, a visionary leader whose contributions have significantly shaped the field of eye care. He is not only a doctor of medical sciences, but also a respected professor and academician of the Academy of Medical and Technical Sciences of the Russian Federation, and the founder and head of Crystal Vision Eye Clinics. Please join me in extending a warm welcome to Professor Igor Aznarian, who will deliver a keynote speech.
Dear colleagues, dear friends, today is a very significant day for the entire Crystal Vision team. It's a great honor for us that you consider it possible and necessary to engage our expertise in the work of the medical community of the Kingdom of Bahrain. Our activities in the ophthalmological industry have always been focused on the creation of the avenues in the medical practice in broad cooperation and partnership with our colleagues. These avenues involve clinical activity, the organization of the research in the field of ophthalmology, the management details in this highly specialized ophthalmological industry. The organization of manufacturing of new devices of ophthalmological practice, involvement into the global international system of postgraduate education of ophthalmologists and beyond. We are deeply grateful to our partners, Bahrain Specialist Hospital, for their active and highly productive cooperation during the preparation phase of Crystal Vision project. The communication with the entire BSH team during the implementation of the project was as effective as it was incredibly pleasant, both from a professional point of view and in terms of personal relationship development. Dear colleagues, we intend to implement our activities across the entire spectrum of ophthalmological services, including such services as anterior segment surgery, vitreoretinal surgery, corneal surgery and transplantation, ophthalmo-oncology, therapy of inflammatory diseases and diseases of the vascular system and fundus, treatment of diabetic eye diseases. Colleague, we put special emphasis on pediatric ophthalmology and strabismology, disorders of the oculomotor system. We will not only introduce advanced international practices, but also share our unique system for the treatment of various types of strabismus, congenital eye syndromes, systems for the treatment of refractive errors, including laser technology for children, and stabilization of progressive myopia of children. In Bahrain, we will introduce completely new methodologies for low traumatic surgery and mathematical modeling of surgeries for the oculomotor muscles, as well as a system for post-surgical restoration of visual function and reflexes, which makes it possible to entirely rehabilitation our little patients in 98% of cases. Colleagues, each and every ophthalmologist in Bahrain will be able to join our work and apply certain techniques into their practice. We will be happy to facilitate this cooperation. Let me once again thank everyone involved in our partnership for our excellent and productive work. I would like to express my special gratitude to Mr. Hamid Rashid Al-Zayani, whose blessing of this project launched its implementation. Also, please accept my personal gratitude to Dr. Najah Al-Zayani, Dr. Qasim Ardati, Mr. Majed Ardati, Mr. Bill Mir, and the team of BSH. Also Dr. Sati Agagulan and Ms. Elena Kazakova. And of course, I want to thank Mr. Onik Aznaurian, my brother and partners in all endeavors. Dear colleagues, we hope that with God's help, we will develop both our fruitful cooperation and special relation with you for benefit for our patients. Thank you.
Thank you so much, Professor Igor. As we prepare to delve deeper into tonight's seminar, it is my pleasure to introduce our distinguished panelists, starting with Dr. Professor Igor Aznorian, Professor, Founder and Head of the Crystal Vision Eye Clinics, Dr. Oganes Oganesyan, Professor, Ophthalmologist, Ophthalmic Surgeon, Dr. Anush Amirian, Associate Professor, Ophthalmologist and Ophthalmic Oncologist Surgeon. Each of our panelists brings unique perspectives and expertise to our event, and we look forward to their valuable contributions to our discussions. And of course, allow me to introduce our moderator for this evening, Dr. Agagulian Sati, ophthalmologist, pediatric ophthalmologist. Let's give them a warm of applause.
Good day, dear colleagues. So let me start our scientific program, and let me introduce the first speaker, Professor Igor Aznorian, Doctor of Medical Sciences, founder and head of the Crystal Vision Pediatric Eye Clinics in Russia, with a talk, System for Mathematical Modeling of Surgical Treatment of Strabismus using the Strabismus method. This talk is written in Russian with translation into English with the use of artificial intelligence.
Good day, dear friends, dear colleagues. I am pleased to welcome all of you in this marvelous country, a gem, one could argue, of the Arab world, the magnificent city of Manama, Bahrain. It is truly an honor to have you here, and I hope you enjoy your time in this beautiful place. We deem it a great honor to be present, to have the opportunity to meet with you, and to convey to you the information, insights, and experiences that we have to offer in order to foster a meaningful exchange, facilitate knowledge sharing, and promote mutual learning between us. And today, as part of this exchange of experiences, I am giving my first lecture. The presentation is dedicated to the surgery of the oculomotor apparatus, specifically focusing on the mathematical modeling of strabismus surgery. I am excited to share my knowledge and insights in this field with the audience. It is a great opportunity to contribute to the exchange of ideas and learning in the medical community. All of us are well aware that in order to carry out an operation with precision and accuracy, it is imperative to have certain predetermined starting points in place. In order to achieve a stable and symmetrical position of the eye, it is crucial to have a thorough understanding of where, how, and by what degree the eyeball needs to be rotated. Additionally, the amount of recession or plication, as well as the need for folding or resection, must be accurately determined. These factors are necessary to unfold the eye and ensure its stable and symmetrical positioning. As it is widely known, all the various systems that currently exist are not always precise, and there is a very large range between what the optimal recession or resection could be at the same angle of strabismus. This lack of precision in existing systems highlights the need for improvement and further exploration in order to achieve more accurate and consistent results in the treatment of strabismus. We know patients who have, for example, a 15-degree angle. We perform standard procedures on them, following the Parkes table, for instance, or using other tables for our interventions. It provides assistance to certain individuals, while for others it is not effective. According to our data, the table named Parkes, therefore, proves to be the most efficient when in 65 to 70% of patients, from 1005, 70%. So, what is our actual understanding of curing strabismus? Yes, that is something that needs to be specifically noted and taken into consideration. This is the symmetrical position of the eyes. This represents high visual acuity, and this demonstrates the stereoscopic nature of vision, also known as stereopsis. This is the goal that we must achieve collectively. And to accomplish stereopsis, we need to ensure that the positions of the eyes are symmetrical and aligned. Here are multiple options available for tables that are commonly used for performing calculations and data analysis. All of them are based on empirical data. They do not take into consideration any of the tables. That is important to note. They do not consider individual parameters. The size of the eye, whether it is big or small, and its shape, regardless of whether it is steep or not, have a significant impact on the outcome when we perform the same recession, resulting in different effects. In this specific case, we are referring to the fact that these individual qualities are not being properly taken into account or given due consideration. Due to this inadequate accounting, there exists a broad spectrum of efficacy in surgical intervention, and numerous individuals even end up feeling disillusioned with this form of treatment, expressing doubts about its potential effectiveness. That is the reason why we contemplated the factors that actually contributed to this specific situation. And upon reflection, we arrived at the realization that there exist particular anthropometric parameters, certain elements associated with the measurement of the eyeball, which directly impact each other in a mathematical dependency. They are related in terms of trigonometry. And thus, accordingly, we have undertaken a mission to identify and understand this interdependence. We identified it, developed a mathematical model using a special formula, and created a framework to implement and test the model accurately. We have obtained the appropriate copyright certificates, and as of the present moment, there is indeed an existence of such a program. We utilize the Strabismus technology for individualized calculation of strabismus, ensuring accurate diagnosis and treatment for each patient. Which parameters have an impact, correct? So, precisely which parameters are we actually discussing? Those are absolute. Observe that no additional information is required. These parameters are the ones that truly determine the effectiveness of the operation. Well, obviously it is the angle of strabismus first and foremost. We cannot escape from it. It is the front-back axis, the length of the front-back axis measurement. This is the axis that is perpendicular to the main axis. It represents the width of the object. And it is always, as you understand, the same. The eye can have a spherical shape, in which case the transverse and longitudinal axes are equal. The eye can also have a flattened ellipsoidal shape, in which case the transverse axis will be greater in length than the longitudinal axis. And the eye can be elongated like an ellipsoid. In this case, the longitudinal axis is longer than the transverse one. The size of the corneal diameter plays a vital role in determining the final shape of the eyeball, as it is the corneal diameter that ultimately determines the overall dimensions and curvature of the eyeball, which in turn affects visual acuity and refractive errors. So in this table, it demonstrates how, by utilizing biometric indicators, we are able to achieve certain results and how this correction process works. Please take a look at the table and draw your own conclusions based on the information provided in order to gain a better understanding. Analyze the extent to which each parameter affects the correction result. It is apparent that all parameters have a similar impact, indicating that the program itself enables us to provide precise operational calculations with an accuracy of plus or minus 5 degrees. This ensures that our operations are conducted with a high level of precision and reliability, as we can confidently deliver accurate results within a narrow range of plus 5 degrees to minus 5 degrees, guaranteeing utmost accuracy and dependability in our calculations for precise operation. This is the ultimate level of accuracy that is currently available, and believe me, it is entirely achievable thanks to the utilization of this software solution. When discussing recession, whether bilateral or unilateral recession in this software, it is imperative to take into account one very important factor that should not be overlooked. What is this thing? This is the thing that follows. That muscle strength has a point of application, and depending on the location where this muscle force is applied, it determines how the eyeball will behave based on the specific point of application. The behavior of the eyeball is influenced by the precise location where the muscle force is exerted. If the muscle is attached in front of the equator, for example, as it naturally occurs, the vertical equator of the eye, here it is drawn, then moving this muscle along the eyeball during recession towards the equator does not produce a torsional effect, because the point of application of the muscle force is right on the equator, exactly at the midpoint between the anterior and posterior poles of the eyeball. And it is only when we cross the equator, solely in this particular case, that we have, accordingly, rotational effects taking place as a result of the Earth's rotation. Arrive at the equator, the turning effect begins to take place. The change in direction starts to manifest itself once we cross the imaginary line. In other words, it is imperative to calculate with precision and accuracy starting from the equator, from the limbus to the equator, and then further from the equator to reposition the muscle. Only in this case will we achieve a good result, an accurate one that our program provides us. Therefore, the individual calculation Strabo system that we have discussed so extensively, you have the option to download it at this particular location by utilizing this QR code and implement it within your professional activities, thereby enhancing your practice and achieving more accurate results in your work. Here I must also mention one important thing. Here are our patients prior to and following the operation. You can observe the remarkable results we accomplish. And here I must say one important thing. In order for this program to be maximally effective, it is crucial to apply its corresponding surgical technologies accurately. Due to the utilization of thick threads such as 5.0 and 6.0, the employment of various scissors during surgery, significant bleeding, and other contributing factors, it leads to the formation of scars and worsens the prognosis, resulting in a deteriorated outcome for the patient and a more challenging recovery process. As a result, we have devised a cutting-edge system for minimally invasive surgery through the utilization of a high-frequency radio knife, which enables the execution of such surgeries in a bloodless and extremely elegant manner, with great precision. In the present day, they have acquired an elegance comparable to procedures such as phacoemulsification, which is used for treating cataracts, for instance. So there, everything is extremely delicate, elegant, and we do not cause any damage to the muscles. We make an effort to avoid damaging the vessels. We do not cause any harm or injury to the tissues that envelop or cover the muscles that are an important part of the body's structure and movement. All of this is preserved and heals quickly for us. On the same day, we open our eyes, minimal swelling, everything heals quickly. And most importantly, there is no excessive scarring process that undermines or diminishes the final outcome of the surgery. So that is the program we currently have for you. Thank you so much for your kind attention and support.
Thank you. So colleagues, we have 3 minutes for Q&A. If there is questions from audience, we are ready to answer on that. If there are some questions? Okay, maybe they will be later. So I'm giving to Dr. Oganisan.
Thank you. So next speaker will be Balasanyan Victoria, PhD, head of the clinic department of the Crystal Vision Eye Clinics. Topic of her talk will be low traumatic surgery for strabismus and nystagmus from diagnosis to surgery. Due to circumstances beyond her control, unfortunately she wasn't able to attend in person, so her presentation was pre-recorded. So please, switch on.
Dear colleagues, thank you for your interest in our meeting. I apologize, but for objective reasons I cannot attend the meeting in person, but hope to meet everyone soon. So, continuing the topic initiated by the professor, let me tell you about our unique treatment approach of ocular motor system disorders, from the diagnostic phase to the minimally invasive surgical intervention technique. Strabismus and nystagmus are not only cosmetic defects. These conditions disrupt the functioning of almost all parts of the visual analyzer and may be accompanied by a range of visual disturbances. In the visual centers of the cerebral cortex, monocular images perceived separately by the left and right eyes are not fused into a single visual image, resulting in double vision of an object. To protect against double vision, the central nervous system inhibits signals received from the deviating eye. Over time, such condition can lead to amblyopia. It's a functional reduction in vision in which the deviating eye is almost or completely not involved in the visual process. Furthermore, strabismus adversely affects the formation of the sight, contributing to the development of introversion, negativity, irritability, and also imposing restrictions on career choices and areas of activity for an individual. That is why the treatment of strabismus requires a comprehensive and fundamental approach. Currently, there are no unified standards for the diagnosis and treatment of pediatric eye diseases. It makes difficult the accurate diagnosis and reduces the effectiveness of treatment. That is why we have developed and implemented, under the direction of Professor Igor Aznorian, a modern comprehensive technology for diagnosing and treating eye diseases in children. The Strabicare system is a comprehensive treatment program for strabismus. This program includes precise diagnosis of eye movement disorders, a mathematical modeling of the surgical intervention, minimal invasive surgical technique, and development of binocular functions through conservative treatment in the post-operative period. In this presentation, we will focus on the comprehensive diagnosis of eye movement disorders and minimal invasive surgical intervention techniques. Any treatment should start with an accurate diagnosis. For this purpose, all our patients undergo an extensive ophthalmic examination, which may be supplemented with various diagnostic tests as needed to clarify the ophthalmological status. As for the standard diagnostics of the eye movement system, special importance is placed on synaptophore examination, which should include measurements of objective and subjective angles of deviation. In our clinics, we conduct more than just routine examination of eye movement disorders. In addition to the traditional synaptophore examination, we offer the use of a video oculograph for accurate determination of the angle of strabismus with and without spectacle correction, for defining nystagmus characteristic, and identifying the point of ocular oscillation blockage. This device, developed by Professor Igor Aznorian, the authoring team of the Crystal Vision Clinics, and developers from Barcelona. Video oculograph enables examination of eye movements in natural conditions. Assessment of a deviation occurs automatically in all gaze positions. Accurate evaluation of the strabismus angle is possible even with low vision and at any distance. Not only the horizontal and vertical components of strabismus are evaluated, but also cyclodeviations. When examining patients with nystagmus, the device allows for an objective assessment of the amplitude and frequency of oscillatory movements in conditions that are as close to natural as possible. The most exciting part is that in near future we will be able to conduct examinations using this device for our patients in Bahrain. In the automatically generated report, we have the ability to compare the deviation angle in each gaze direction with both eyes open and during the cover test. This is how a nystagmography protocol looks like. We determine the gaze position at which nystagmus is blocked. The software calculates the point of blockage automatically. What is important that this method we can use in small children, patients with low vision, and with no central fixation. When it comes to very young patients, for most doctors, the question of strabismus surgery for infants still raises a lot of concerns due to the inability to determine the exact deviation angle in such patients using standard methods. However, it's important to remember that we mustn't lose valuable time of a sensitive period. So on this slide you can see the portable device enables remote 1 meter distance measurement of reflection, deviation angle and interpupillary distance in patients as young as 6 months old. In our calculations, we take into account not only the angle of strabismus, as is usually the case of planning traditional surgical intervention. We use also a number of anthropometric parameters significant for subsequent surgery calculations. So during preoperative preparations, we conduct all the necessary measurements. In addition, for the youngest patients, we have the ability to conduct preoperative examinations under the general anesthesia with measurements of all necessary parameters. Once we have obtained all the necessary data, we start mathematical modeling of the surgery and determining the volume of the surgical intervention. So everything about the mathematical modeling, Professor Aznaurian has already detailed. I just want to emphasize once again that the use of the Strabismus program allows us to achieve the most accurate results from the surgery. However, precise diagnosis and calculations are insufficient if the surgical technique itself doesn't ensure high accuracy of the intervention. Just for this purpose, we have developed a special minimal invasive surgical technique. The first condition, ensuring a gentle impact on the eye tissues, is the preservation of vascular integrity. Intraoperative bleeding prolongs the surgery time. Additionally, blood spilled in the tissues leads the inflammation, postoperative swelling, and stimulates the formation of fibrous tissue in the postoperative period. The second criterion of minimal invasive surgery that we consider is minimal trauma to the connective tissue. So this leads to a reduction in the adhesion process in the operation area. And finally, it is necessary to use suture material that would ensure the conformity of muscle apposition to the calculated precision of the surgery. This is so that the trauma caused by needles and knots doesn't affect the position of the muscle in the postoperative period. So on this slide, you can see our surgical technique. So to create access to the muscle, we do not use cutting instrument like scissors. In our practice, we use a radio wave knife, which dehydrates cells, resulting in tissue dissection with a simultaneous coagulation and without any physical manual pressure. The incision is made in a way that preserves the muscle sheath, ensuring minimal development of adhesion process in the future. We use 7.0 vicryl as a suture material. The suturing is done with a special right hook with a groove, which helps avoid the scleral damaging. When suturing the muscle, needle insertion and withdrawal are performed in the least vascular area. Following this, we measure the equator point from the limbus using a caliper, then measure the point for the planned recession based on previous calculations. I would like to emphasize once again that performing a deep recession behind the equator is crucial for achieving the desired outcome and providing a torsional effect of eyeball. For muscle detachment, we also use radio wave knife and a hook with a special protector to prevent damage to the surrounding tissues. Knots are tied using a special technique that doesn't disrupt the ciliary vessel damaging. and ensures the muscle adheres as accurately as possible to the new calculated attachment point. So minimal invasive strabismus technique allows to perform the surgery in such a way that after 3-6 months, the postoperative scar is not detectable even under the microscope. The use of precise preoperative diagnostics, our unique minimal invasive surgery technique, combined with the Strabo mathematical modeling method, has enabled us to achieve a surgical dosage calculation accuracy of 5 degrees. We have been successfully using the Strabo technology for more than 20 years. During this time, we have operated on thousands of in the post-operative period, as well as the rehabilitation period for patients. So when the child could return to daycare or school. We operated on 7,207 children with concomitant horizontal strabismus, with 1,525 surgeries performed using the conventional surgical technique and 5,682 using our proposed radiofrequency minimal invasive surgery technique. As you can see on the slide, our proposed surgical method allows for a reduction in postoperative tissue swelling and hyperemia in over 19% of cases. The rehabilitation period can be shortened to just 3 days. Therefore, the use of the minimal invasive strabismus surgery technique leads to a significant reduction in tissue hyperemia and swelling in the postoperative period, a considerable decrease in patient rehabilitation time, and practically eliminates the formation of the adhesion. Dear colleagues, thank you again for your attention.
Dear colleagues, maybe there is some questions about the method, the technology that Dr. Victoria was telling about. Yes, please. Yeah, my microphone will
Sure. Thank you very much for this very comprehensive and up-to-date technique to treat squint with minimal invasive technique. The point I would like to raise, you are using the microelectric cautery to cut the tissue instead of the normal conventional scissor. Now, one of the things which we are always scared of is the ischemia, because the cautery will cause ischemia, and the conjunctival tissue is such a vascular, highly vascular tissue which need a good perfusion and good blood supply to enhance and also to secure the good healing of the wound. Now, any cautery we use in this area might cause ischemia to the tissue, which is not good in the future, because this vasculature of the conjunctiva is very essential for the aqueous outflow, because we have the aqueous inside the eye has a circulation to flow out of the eye through the conjunctival or limbal vasculature, and it will form, the aqueous will form inside the eye by the ciliary body, and then it will get out from the eye through the vasculature of the limbus, which is the connection between the cornea and the sclera. So we need to think of the safety of this blood vessel or micro blood vessels in the limbal area to secure normal outflow of the aqueous and prevent future glaucoma. So this is one point. I admire your idea of cutting the tissue with the electric cautery to minimize the trauma and also to enhance good look for the patient post-operatively. But as I mentioned, we should think of this as a future complication, because this might raise the risk of increased intraocular pressure in the eye. The other things, the other question, is there any way that you could secure the squint correction and also the nystagmus correction by Botox injection. Botox injection, which has really a minimal invasive surgery, and you are not going to cut any tissue, neither in the conjunctiva nor in the muscle. I appreciate your answer. Thank you.
Just like to mention that this is Dr. Mu'min Al-Rifi, who is a very prominent ophthalmology surgeon here in Bahrain, and we welcome him here to be joining us. And I just wanted to introduce him to the group also. Thank you.
Большое спасибо. I speak in Russian, and my colleague translate it, please. Okay. Большое спасибо за вопрос. Очень хороший, интереснейший вопрос. И особенно та часть его, которая касается применения ботокса. Что касается...
Thank you for this question, very interesting question, especially the part that was connected with the Botox.
Но я начну сначала.
I'll start from the beginning.
И будем говорить об ишемии.
And we will talk about ischemia.
Лимбальные сосуды, которые мы частично повреждаем при подобном роде разрезе,
Limbal vascular system that can be damaged during this procedure.
Они имеют свойство очень быстро восстанавливаться, особенно у детей в течение ближайших порядка 2 недель, не больше.
They have a function to recover very fast, especially in kids during the first 2 weeks.
И мы ни разу не видели какого-либо краевого кератита.
And we have never seen the marginal keratitis at children after the surgery.
Что же касается воздействия радионожа на более глубокие структуры, в частности, например, на угол передней камеры,
What concerns of the influence of radio wave knife to the more deep structures, for example, the angle of the eye, the anterior angle.
То, значит, вся прелесть этого ножа состоит в том, что он не нагревает структуры больше, чем на несколько микрон.
It don't warm the structures more than some on the dips of some microns of the dips.
И поэтому никаких структурных изменений внутри ткани не происходит.
That's why we have no any structural
Внутри более глубоких
changes in the deep structures of the eye.
Ну, в том числе и в угле.
And in the angle of eye.
Заживление происходит очень быстро.
We have recovery very fast.
Сама по себе радиоволна обладает также свойством усиливать регенерацию.
And also radio wave knife give us a chance to have make a recovery more fast and regeneration also.
И мы в тот же день пациенту открываем глаза.
And the eyes of the kids are going to be opened at the day of the surgery.
И в тот же день он может смотреть телевизор, играть и так далее.
And at the day of the surgery he can play, watch TV and read.
Вот это то, что касается радионожа и его свойств, а также этого вида разреза.
It what concerns the radio wave knife and the type of the surgery.
Я полно ответил на ваш вопрос или что-то осталось?
Maybe you have any other questions regarding that.
Тогда по второй части, то, что касается нистагма.
And what concerns nystagmus?
И применение ботулинтоксина.
And using of Botox.
Применение ботулинтоксина у пациентов нистагмов мы практиковали одно время, и мы нашли, что эффект он очень непродолжительный.
We have used for some time a Botox for patients with nystagmus, and see that the prolongation, duration of the treatment was not so long.
Ну, максимум 5-6 месяцев, и в принципе и амплитуда, и частота нистагма доходили до прежних значений.
Maybe for 5-6 months the duration was elongated, and the frequency of nystagmus after the treatment in 5-6 months was the same as before.
Поэтому мы приняли решение пойти другим путем Кастенбаума, который применял операцию, значит, блокировки за счет вот этого его известного протокола.
That's why we start to make Custom-Baum surgeries for nystagmus by his protocol.
И единственное, что мы туда внесли, и, как нам кажется, это существенно влияет на результат операции.
What we have changed in this protocol, and we think that it influenced very much on the result of the surgery.
Мы до операции очень точно, с точностью до 1 градуса, определяем точку блокировки нystagma.
We, before surgery, measure the null point of the nystagmus with the accuracy of 1 degree.
Это посредством технологии Gaze Lab, которую показали.
With the videography technology.
И по вертикали, и по горизонтали находим эту точку.
By vertical and horizontal axis we found this null point.
И потом по системе Страба, по системе вот этой математической модели, мы рассчитываем, насколько нужно развернуть оба глаза.
And by the Strabismus system, we then see and calculate on how we need to turn both eyes and on what side.
Таким образом, мы получаем блокировку или значительное уменьшение частоты в прямом взоре.
By this technique, we have stopped the nystagmus or lower the frequency of nystagmus when the eyes are aligned.
Но, конечно, в крайних отведениях он опять есть при поворотах.
But when the eyes are turning to their left or right, so we have these nystagmoid movements.
Ну, пациенту важно, чтобы у него не было нystagma, когда он смотрит прямо.
For the patient, it is very important not to have nystagma when he is looking straight.
Ну, нам кажется, это надолго, это навсегда, и, как правило, 1 или 2 операций бывает достаточно.
And this surgery is forever, and we see that 1 or maximum 2 surgeries is enough to stop this nystagmus.
Или уменьшится
Or for lowering the frequency
сильно
of nystagmus.
уменьшится.
Lower very much this frequency.
Ну вот.
Thank you.
Thank you.
Thank you. Any other questions? Okay.
Dear colleagues, our next speaker is Oganesyan Oganes, Professor, PhD, ophthalmologist, ophthalmic surgeon, with the topic Modern Selective Keratoplasty.
Good evening, everybody. This is my first time in Bahrain, and I'm really touched by the hospitality. I am happy to be here. Excuse me. Somebody can help to switch my notes. Thank you. So I'm really happy to be here today, and I'm grateful for the opportunity to share some insights on modified Descemet membrane endothelial keratoplasty. My presentation will focus on quatadimag, hemidimag, and 3-quatadimag. Let's look at the details of these approaches. Sorry. Okay. Different techniques of lamellar keratoplasty have become first choice surgery for treating selective corneal pathology. However, the growing demand for tissue creates challenge, aggravating the shortage of donor tissue in many countries. In a few words, the lifespan of population, the rate of Fuchs dystrophy, and the donor ages increase. But at the time, the pool of intact donor tissue decreasing. The concept of customized corneal surgery and multi-transplantation using modern technique of keratoplasty offer a fast and feasible solution. Here is an example of rational donor tissue usage, Descemet membrane graft preparation from the post-LASIK donor eye. We can use Descemet membrane even from the donor eye with radial incisions. In fact, Dr. Zirm was not only the first person to perform a successful corneal transplantation, but also the first one to perform a multi-transplantation as an example of rational use of donor tissue. Dr. Zirm performed 2 consecutive penetrating keratoplasty from a single living human cornea. There are several modern publications about using one donor cornea from multiple transplantation, for multiple transplantation. Earlier, we described the feasibility of consecutive use of a single donor cornea in 5 patients with corneal pathology who required anterior, lamellar, and endothelial keratoplasty. Briefly, the technique of graft preparation is follow. Descemet membrane stripping from the posterior stroma. During stripping, the trabecular meshwork keep intact and pulled together with Descemet membrane. After staining Descemet membrane, the tissue positioning stromal surface down onto a soft contact lens, which put on a bottom punch. The peripheral rim with the trabecular meshwork removing. We're using custom-made punch for linear cutting of Descemet membrane and obtaining 4 quarter pieces of Descemet membrane, 4 grafts. So 1 donor cornea tissue we can use for 3 recipients. Stroma can be used for deep anterior lamellar keratoplasty and Descemet membrane for 2 hemidimag. Also, we can use 1 cornea tissue for 5 recipients, for 1 DALK and 4 quatadimag. Theoretically, the number of transplantation can be increased up to 6 if donor limbal tissue is used for allolimbal transplantation. The surgical technique did not differ from our conventional DMAG technique. In a few words, the main limbal tunnel incision of 1.6 millimeters making with a single paracentesis at 10 o'clock position, Descemet hexis performing under the air, always bigger than the graft, the Q graft injecting into the host anterior chamber through the limbal incision, and unroll, and the interior chamber fill with air. Performing QDMAG is absolutely logical because the pathological changes in Fuchs dystrophy are mainly limited to the central zone of the cornea. That does imply, however, that strict case selection for QDMAC is necessary. In addition, QDMAC allows retention of more host cells. At the same time, it creates favorable conditions for endothelialization. Partial DMAC has some drawbacks, unfortunately: an acceptable increasing time for graft preparation, limited indication, only Fuchs dystrophy, prolongation of recovery time, and requires strict case selection and good logistics. So, here are our conclusions. Split and divide approach can reduce the need of corneal tissue. The main advantage of QDMAC and HemiDMAC is in a much more efficient use of donor tissue. Such approach could help dramatically reduce the shortage and the cost of corneal tissue. Strict case selection is necessary, and more case and long-term data are now required. My second topic is about 3/4 DMAC. It is well known that GDD, I mean glaucoma drainage devices, is a disadvantage factor for graft survival after penetrating keratoplasty. Also, secondary graft failure after DSEC and DMAC in eyes with glaucoma drainage devices occurs in up to 35 to 74% of eyes at within 24 months. The rate of graft failure in eyes with GDD is significantly higher than in eyes after glaucoma surgery without glaucoma drainage devices, and even more so in eyes without glaucoma surgery. The endothelial cell loss after DSEC in eyes with glaucoma drainage devices is around 61% during the first year, which is much higher than in eyes without glaucoma drainage devices. According to literature, graft failure in eyes with glaucoma drainage devices occurs earlier after DSEC than after penetrating keratoplasty. The mechanism of endothelial graft failure in eyes with GDD is poorly understood. The most possible explanation might be mechanical damage of the donor endothelial cell by an intermittent or constant touch between the silicone tube and the graft. There have been few case reports of DMAC for eyes with glaucoma drainage devices tubes. Larger cases showed good early outcomes, but high failure rates over long term. We present a 3/4 Descemet membrane endothelial keratoplasty technique for optimizing the separation between the graft and the glaucoma drainage device's silicone tube for treat pseudophakic bullous keratopathy. Briefly, the technique of graft preparation is following: Descemet membrane stripping from the posterior stroma. During stripping, the trabecular meshwork keep intact and pulled together with Descemet membrane. After staining Descemet membrane, the tissue positioning stromal surface down onto a soft contact lens, which put on a Barham punch. The peripheral rim with trabecular meshwork removing, and with keratome, we perform 2 perpendicular cuts and triangular shaped part of Descemet membrane cutting out. The main tunnel incision of 1.6 millimeter performing with a single paracentesis at 10 o'clock position. Descemet is creating under the air, but with the part of the Descemet membrane under the silicone tube leave untouched, and this is very important. The graft, 3/4 graft, injecting into the host anterior chamber through the main incision, positioning centrally, and partially unrolling to achieve visualization of the site with missing part of Descemet membrane. Then rotating, such as missing part should be located under the silicone tube of glaucoma drainage devices, and fully unrolling and anterior chamber filled with air. The absence of the graft under the tube could help avoid the contact between the silicone tube and the graft. Such contact after conventional circular DMAC may induce chronic endothelial cell loss and graft failure. To avoid or minimize cell migration from the graft onto recipient stroma, the part of host descemet membrane under the silicone tube is left untouched. The absence of chronic donor endothelial cell migration to the tube region may help retain the pool of donor endothelial cells on the graft itself. To avoid or minimize cell migration from the graft, using large diameter graft may compensate for the missing tissue quota in terms of absolute cell number, especially since large diameter graft include the corneal periphery, in which the endothelial cell density is much higher than in central part. So we demonstrate the technical feasibility of 3/4 descemet membrane endothelial keratoplasty in eye with pseudophakic bullous keratopathy in the presence of GDD tube. The absence of a donor descemet membrane and donor cell above the silicone tube exclude direct tube contact with the graft. Longer-term studies are needed to show the effect of this modified graft pattern and dimension on transplant survival. Thank you for your kind attention.
Thank you, dear colleagues. Maybe there are questions to Dr. Oganisyan? Any questions about keratoplasties? Okay. Thank you so much. Let me introduce next speaker, Amirjana Nush, Associate Professor, PhD, Ophthalmologist, Ophthalmo-oncology Surgeon. Her topic will be current concepts in ocular oncology.
Good evening, dear colleagues. Thank you for invitation, and it's my great pleasure and honor to take part in such important event. Today I will talk about ocular oncology current statements. Ocular oncology is divided into 3 branches. It's impossible to cover everything, so I decided to focus my talk on tumors of the eye and eye adnexa, especially on malignant tumors. Anatomy of the eye adnexa is well known, and each part of it can be involved in tumoral process. Melanocytic tumors are the most important types. On eyelid, they can be represented by both non-pigmented and pigmented forms that can be benign, like this on this picture you can see, or malignant ones. Melanocytic tumors also can arise in conjunctiva. Signs of progression include increasing in sizes, color change, appearance of vessels in the lesion, pigment grouping, appearance of afferent feeding vessels. Generally, treatment of these lesions only surgical with reconstructive surgery using local tissues. Malignant pigmented neoplasms are another matter. Eyelid melanomas composed up to 1% of all eyelid tumors and less than 1% of all cutaneous melanomas. They develop both de novo and in patients with primary acquired melanocytosis, or can be a result of the progression of nevi. They can give regional and distant metastases and lead to death patient of metastatic disease. Conjunctival melanomas are also aggressive, characterized by rapid growth, and sometimes patients come to doctors with quite huge tumors. Besides melanomas, there are different types of eyelids and conjunctival tumors, both benign and malignant. The most frequent tumors are carcinomas, most of them basal cell carcinoma, less squamous cell carcinoma, sarcomas, and lymphomas. To make diagnosis, traditionally are used clinical, instrumental, and morphological examination. Besides, these patients are examined to exclude regional or distant metastasis. Echography, CT, MRI are significant method to recognize topography of the tumor and its spread into the orbit. Surgical treatment has found great application for epithelial tumors and include many well-known techniques. Treatment in this case may consist local excision of the tumor without reconstructive surgery or with different reconstructive options. For example, closure the defect with the local tissues, and main surgical options is controlling free tumor margins of lead to prevent local recurrences. It's also effective to excise tumor and close the defect using free skin flaps. Here you can see patients treated by this technique, and this technique also gives good results, functional and cosmetic good results. In cases of huge tumors, different reconstruction modalities are used. As you see, this young lady with completely destroyed lower lid, outer corner of eyelid and part of the upper eyelid, and she underwent different, very difficult surgical removal with reconstructive surgery, and at last we have very good cosmetic and functional results. Anyway, sometimes it's impossible to perform surgery. There are cases with large tumors involving in process different part of the eye and the nexa, skin, conjunctiva, tarsus, tumors with the lid extraction. In such patients, higher risk of non-radical surgery, traumatization, in cases when we don't wait for good functional or cosmetics results. Non-surgical treatment is very important in elderly patients with concomitant somatic pathology. So another tool of treatment is radiotherapy. Radiation therapy includes two branches: brachytherapy, contact radiotherapy, using different radioactive plaques, and external radiation, such as photonic and corpuscular. In Moscow, Helmholtz National Institute there are huge experience of using radioactive plaques with isotope strontium-19, which is beta irradiation. They are very huge experience with X-ray examination and treatment and proton beam irradiation for these patients. Surgery can be part of different kind of radiation: X-ray, proton beam, and radio and brachytherapy. Depending on the tumor size, the radiation therapy carried out in these three ways. Sometimes in melanocytic conjunctival tumors, for additional therapy, it's very helpful to use mitomycin C as a chemotherapy in eye drops. The main purpose of the radiation component is to eradicate the residual tumor after surgical treatment to make the condition to an operable form. And the surgical component is to create conditions for effective dose distribution in the target by reducing its volume and eliminating the radio-resistant parts of the tumor. Reducing the dose and the volume for radiation, we can reduce the safety of radiation complication and improve patient and improve quality of life of this patient. I would like to demonstrate to you techniques of radiation. The methodology was developed in Russia by my teachers, Professor Brovkina, Valsky, Zerubey, in 18th, 19th, and we use this technique up to nowadays. Here's a fixator device and set of strontium plugs for radiotherapy, and you can see a patient position during the treatment. It takes about 30 minutes for one fraction. So let me demonstrate some results. Here you can see two cases of using strontium plug brachytherapy as a single therapy of conjunctival and corneal melanoma. And here you can see on the second case, residual pigmentation and also radiation cataract, which can be removed very easily on the next step. There is no tumors after brachytherapy in the other case. Here is another case with a flat, but you can see very wide melanoma, and we decided to irradiate this patient, then surgical treatment, and you see the clinical case before and after this technique. A patient with advanced melanoma, and you can see in this picture there is flat, non-pigmented tumor cover more than 90% of the cornea. And here he is after 7 years of treatment, and there is no tumor, there is no signs of recurrences. In such difficult forms, local surgical treatment sometimes impossible, and the only method to try to save the eye like an organ is radiotherapy with chemotherapy with mitomycin. And it's to make surgery, we can it will be a very high risk of local recurrences and metastasis. You can see in this picture, just after treatment, in 1.5 years after treatment, we have no signs of tumors. Very good result. Here is another type of treatment with complex. Here possible to use surgery, radiotherapy, and chemotherapy with mitomycin C. Very good result in this patient. These kind of treatments are alternative to orbital exenteration. So combined treatment is very important part in patients with lymphoproliferative lesions. So surgical treatment is important to reduce tumor size, to create optimal condition for radiotherapy. You see patient with lymphoma before and after treatment. And here is another such case. You see very huge salmon mass in fornix before and after radiotherapy. So this patient with squamous cell carcinoma, also a very good result after treatment. It was possible to save eye and no signs of tumor after 70 months. So here we can see basal cell carcinoma. We know that basal cell carcinoma most often we see in elderly patients, so surgery not always comfortable for this patient, so radiotherapy is the first step for the treatment. And here you can see just after 6 months in the treatment, we have very good results. So in this example and combined treatment of the nodular form of basal cell carcinoma, after surgery we removed the prominent part of the tumor, and after surgery after a few days we irradiated this zone. So when the tumor thickness more than 3 millimeters, it's better and more effective, in our opinion, to use X-ray. And also, I repeat that it's very important for elderly patients to not undergo surgical treatment. And here you can see very good results after treatment. It's very important in this case is to prevent orbital extension, especially in the medial angle of the eye. And at last, proton beam therapy is usually used in advanced forms in huge tumors, and in most of cases it can be alternative to orbital exenterations. Yeah, here you can see this patient with very huge basal cell carcinomas before and after radiation therapy. So another patients with also very advanced cases spreading even in paranasal sinus, and it was possible sometimes to help to prevent exenteration. Unfortunately, the method of choice of very huge tumors stay such kind of surgery like an exenteration, though we do everything to minimize such kind of the treatment. And in conclusion, the choice of treatment of patients with eyelids and conjunctival tumors is strongly individual and depends on type of tumor. It's spread also on age and somatic status of the patient. Radiation therapy is an important component in treatment of malignant tumors. It can be used both as an independent method and as an adjuvant to surgical treatment. And brachytherapy with strontium is the only method of the treatment for diffusely advanced melanocytic tumors. Radiation therapy can reduce the risk of local recurrences and avoid mutilation surgery. Thank you for your kind attention.
Thank you so much. Any questions to Dr. Amirian about oncology, maybe some cases that you want to share? We have a question here. Yes.
Thank you again for the last two talks. Just a comment I would like to raise for Bahrain Specialist Hospital. If they can bring up this new technique of treatment of DMEC, which is descent membrane keratoplasty, as an alternative to full thickness keratoplasty, and also this new technique of combining the chemotherapy with early surgery for the ocular and orbital tumor. This is going to be a great breaking through in our management of the eye patient, because currently we don't have an eye bank in Bahrain. And the main challenging for us actually is there is no donation. Nobody from our Bahraini family will donate their eyes after death. So we have really a great challenging in getting the full thickness cornea from abroad. And this is very long procedure, and it's not easy to get. So if you can provide this service of partial thickness corneal graft to save the blind eye from dense corneal scarring or some complication from cataract surgery, that will be a great breaking through news. The other things for the ocular tumors. Now, unfortunately, we are obliged sometimes to inoculate the eye to that extent to save the patient life from the expansion of the tumor. So if you can combine this early chemotherapy with minor surgery, this is going to be a great breaking through news to our Bahraini patient, and hopefully with the collaboration between Bahrain Specialist Hospital and Crystal Vision, we'll be able to achieve this. Thank you.
Thank you. Any other comments or questions? Okay. Thank you.
So one.
Thank you very much.
And my pleasure to invite Maya Talalishvili, ophthalmologist, strabismologist. Her topic is vision therapy in children with refractive and oculomotor pathology. Please.
Dear colleagues, good afternoon. It's a great honor for me to tell you about the unique developments of Crystal Vision, which we have brought with us from Moscow to apply them for our patients in Bahrain. Let me tell you about the possibilities of conservative treatment of children with refractive and oculomotor diseases. I would like to introduce you Dow's care system. This system represents a modern comprehensive approach to the treatment of several eye diseases. The system was developed and implemented by doctors of Crystal Vision under the guidance of Professor Aznorian. And Dow's system includes 4 blocks. Dacryo, treatment of diseases of lacrimal apparatus system. Amblio, treatment of amblyopia, diseases leading to the development of amblyopia, and conditions provoked by persistent visual impairment. Visio, treatment of refractive pathologies, including the performance of laser correction of hyperopia and astigmatism in children. And Strabo, treatment of all types of oculomotor system diseases. As was mentioned earlier, before proceeding with the treatment, it's extremely important to thoroughly diagnose a patient to establish the correct diagnosis. All patients undergo a standard ophthalmological examination, and in some cases, to clarify the ophthalmological status, we conduct additional diagnostic procedures such as OCT, visually evoked potentials, electroretinography, computer perimetry, and MRI of the orbits according to the International Ophthalmological Protocol. Based on the results of these studies, we can develop a strategy for further treatment and make a prognosis about the possibility of improving visual function in a particular patient. Establishing the correct diagnosis, we prescribe the child an appropriate course of treatment. Within 10 days, the children come to the clinic to undergo the course of therapy. All procedures are carried out together with the nurse, and the doctor monitors the treatment process daily and if necessary, correct it. For the treatment of each pathology, there are a list of necessary therapeutic procedures, which include physiotherapeutic and electrophysiological procedures, magnetotherapy, procedures that stimulate the work of the ciliary muscle, the retina, the optic nerve, and thereby stimulating the work of all parts of the visual system. Today, I will focus on the most advanced developments in the field of conservative treatment. It is not secret that the treatment of amblyopia should be timely, and the older the patient becomes, the more difficult it's to get improved visual acuity. And in general, there are a lot of stereotypes associated with the treatment of amblyopia, and that's why the patient with such a diagnosis often hears that their vision will not get better. However, Professor Aznorian developed a unique device called binocular optometric complex, which allows us to treat patients with amblyopia and improve their visual acuity even when it seems impossible. Dr. Aznorian proposed an objective method for examining visual acuity using the BOC device, which is as follows. Reversing chess or linear patterns are displayed on a liquid crystal screen placed in a closed space, mounted on a carriage that moves in the anterior-posterior direction. The carriage is set to the 0 position, corresponding to emmetropic refraction. The size of the patterns is sequentially reduced from the dimensions corresponding to a visual acuity of 15 to 100 to the dimensions corresponding to a visual acuity of 20-25. The BOC device has a unique therapeutic potential and has been successfully used in our clinic for the treatment of patients with high and medium degrees of amblyopia for more than 15 years. And due to treatment with BOC device, it's possible to treat amblyopia even in cases where visual acuity is only 1 or 2%. And at the same time, the speed of patient rehabilitation increased 4 times compared to other less effective methods of amblyopia treatment. The BOC device operates on the principle of biological feedback, which is realized through visual evoked potentials. Visual acuity is assessed by the amplitude of the P100 peak potential. During the procedure, the treatment parameters are adjusted in real time based on the individual response of the visual system. Thus implemented an objective method of assessing visual acuity. The most severe type of amblyopia is meridional amblyopia, which develops in patients with astigmatism, and even among such patients, treatment with BOG gives us excellent results. I would like to present to your attention the data from a retrospective study on the effectiveness of treatment patients with meridional amblyopia using BOG. An analysis was conducted of data from 53 patients who underwent treatment in the period from 2020 to 2022, divided into groups depending on the type of astigmatism. And as you can see, BOG allows for a rapid increase in visual acuity even in patients with astigmatism and meridional amblyopia. Another development by Professor Aznorian, which we successfully use in the treatment of amblyopia, is the Strabo liquid crystal glasses. In the Strabo glasses, the liquid crystal screens are formatted in the form of eyeglass lenses. Unlike previous analogs, these glasses can be used without direct connection to a computer, which allows the patient to undergo treatment outside the walls of hospital and accordingly without limiting the duration of the treatment courses. This disease can simultaneously use corrective lenses. It depends on patient's refractive error, and they are programmed with a special computer program according to the individual parameters of the child, depending on the degree and type of amblyopia. In collaboration with doctors from the Federal Biomedical Agency of Russia, we have done research with the aim of studying the possibility of using liquid crystal glasses in the functional treatment of patients with congenital partial optic nerve atrophy. As a result of using liquid crystal glasses, we observed an increase in visual acuity of the better-seeing eye from 2070 to 2050 and the worse-seeing eye from 2000 to 2050. At the same time, there was a parallel improvement in electrophysiological indicators. It can be assumed that the positive dynamics of these indicators was achieved due to the stimulating effect of visual stimuli presented in an alternating mode. And now we go to the block Straba. Regarding patients with strabismus, the presence of sensory fusion is a necessary condition for the formation of binocular vision and the complete rehabilitation of the patient after the surgical treatment. This is especially important when restoring sensory fusion in children with congenital strabismus. The absence of sensory fusion leads to the inability to form binocular vision, and without binocular vision, the complete rehabilitation of our patient does not occur. That's why we pay no less attention to conservative treatment than to surgical treatment. All our patients in the postoperative period are prescribed a course of Strabo treatment, and such courses are regularly repeated until the complete rehabilitation of the patient. The generally accepted method of restoring sensory fusion is orthoptic treatment on a synaptophore, which is carried out under conditions of rigid haploscopy with various test objects presented to the eyes. The goal of orthoptic treatment is to restore the joint activity of the foveal retinocortical elements of both eyes. Orthoptic methods include exercises on a synaptophore, exercises to restore simultaneous vision, and bifoveal fusion. However, this method has disadvantages. For example, it's necessary to visit a hospital daily, and the time for the treatment procedure is limited. In crystal vision, we improve the development of fusion using liquid crystal glasses, and my colleague, Dr. Satya Gagulan, will tell you about this method of treatment in details. After the development of fusion, we intensify treatment and add diploptic procedures. The task of diploptic treatment is to develop the patient's ability to overcome their perceived double vision through the restoration of the mechanism of binocular visual fixation, or bifixation, which underlies normal human binocular vision. As a result of this comprehensive approach, we can achieve all the set goals: symmetrical eye position, high visual acuity without glosses, and stereoscopic character of vision, and bring joy of crystal vision to our patients. Thank you very much.
Any questions to Dr. Dalalishvili? No questions? Okay. Thank you, Doctor.
Dear colleagues, let me introduce the next speaker, Agagulian Sadi, ophthalmologist, strabismologist, and her topic, rehabilitation of patients after strabismus surgery.
Dear colleagues, thank you for this chance to be in Bahrain. Thank you for having us. So my topic, I will talk about the rehabilitation after strabismus surgery and about the importance of their vision therapy after strabismus surgery. So, as we know, strabismus surgery is only a step in treatment of children with strabismus, and without vision therapy, we cannot recover no sensory fusion, no binocular functions, and so the strabismus surgery will be only for cosmetic functions. That's why when we are talking about strabismus treatment, we need to understand that the principles is to avoid diplopia, is to have an aligned eyes, to develop sensory fusion, 3D vision, and also all binocular functions. How we can do it? We can do it by vision therapy and orthoptic treatments. How we are doing it now? Usually we use Synopta-4. It is a device that we have in our vision therapy in clinic, and kids need to come to the clinic for 10 days, maybe 15 or 20, every day for 50 minutes, and they have different regimes by simultaneously regime, and by this treatment we can create binocular function. For each eye, Synopta-4 provides its image. For example, here we see that left eye see the cat with a tail and the right eye see the cat with ears. And in visual pathways in the brain, when their Synopta-4 is working and a kid is seeing the images, these two images are connected in one, and so we have a chance to create a binocular connections between left and right eye, and to create a sensory fusion, and then binocular vision, and then stereoscopic vision. But this treatment have many disadvantages, and one of them is that there is a lack of compliance between kid, and his doctor, because kid need to come to the clinic, and there is no interest in. He is watching these cats every day for 10-15 days, and we have developed a technology that more effective than Synopta-4 restores sensory fusion in children after strabismus surgery. So about these glasses, my colleague Maya had tell in her talk, and I will talk about how we use it in strabismus. So there is a program that gives us a chance to program these glasses on different blinking. It can be simultaneously, it can be for both eyes, or for only one eye. In strabismus, while we want to recover sensory fusion, we use blinking, right eye, left eye, right eye, left eye. And how we know what the duration of this blinking need to be. We, for that, had an aims of our investigation to determine optimal parameters for visual field separation to restore sensory fusion with oscillating glasses, and then evaluation of the effectiveness of the proposed sensory fusion restoration method. So for that, we use video oculography. This device allows us to understand what are the fixation movements of the right eye and the left eye, and make individual parameters for each kid, so to provide an effective treatment and restoration of sensory fusion for each patient. How we do that? So this device give us a chance to record a duration of the fixation movement, and each fixation movement has two parts. The first one is the latency period, when the eye is starting to understand that he needs to make a fixation movement to see better. And the second part is a fixation movement. So in this picture, we see that the latency period is for 100 milliseconds, and the fixation movement is for 20 milliseconds. So the whole period will be 120 milliseconds that we will put in the program in the computer, and by Bluetooth we'll program these glasses, and we'll give these glasses to a kid, so he will wear it at home for 4 hours in a day for a long time, and we will check a kid for every month. And we have patents for this method as diagnostic, so restoration. So our investigation had 99 patients, and there was two groups. The main group was consisted from 46 patients, and they used daily for 4 hours Strabismus liquid crystal glasses that were programmed by their individual video oculography and fixation movements. The second part, control group, 53 patients, they were undergone vision therapy in clinic for 10-day courses every 3 months, and totally in the year 3-4 courses. And we exclude from this group kids with high amblyopia, with V syndrome, S syndrome, X syndromes, vertical strabismus, and a lack of central fixation. After 1 year, we made and check, and so what we have seen, that in a main group that had wearing Strabismus crystal glasses, as you see, their amount of kids who have stable fusion was 69%. It was more for three times than in control group, because stable fusion there we have in 21%. And also we see that binocular vision during this treatment, we didn't do any other exercises, no diploptic, no computer different programs, was recovered in 39% of kids. It is too much. And then we think that what will be if we will prescribe crystal glasses to the group, to the kids from control group whose sensory fusion was not recovered after the year. And what data we had? So it was like kids with congenital strabismus, and strabismus that was in kids till 2 years of old. And so we see that even in that group, in 1 year, the stable fusion was restored in practically 65% of these kids. That means that the method of Strabismus glasses gives us more effective influence on the visual pathways and more effective restoration of sensory fusion and binocular function. So what we want to say, we understand that the duration, 4 hours a day, 4 hours a day, every day, for a long time, give more influence on the kids' visual pathways and more chance to provide sensory fusion recovery. It is an excellent patient compliance because that glasses like as kids kids, so their parents, because they don't need to come to the clinic every day and to rearrange all their lifestyle. And we provide custom treatment programs for different patients, and each patient have its individual parameters in these glasses. Thank you so much for your attention.
Thank you very much. Dear colleagues, any questions, comments?
Thank you.
Thank you so much to our esteemed panelists, speakers, and moderator. It was truly insightful and informative session. Let's give them a round of applause. Now, ladies and gentlemen, as we are about to wrap up, it is my honor to introduce the Chief Operations Officer of Bahrain Specialist Hospital to deliver the vote of thanks. Please welcome Mr. Majed Ardati.
Good evening, everybody. Thank you very much for giving me the time to address the group. I'd like to, first of all, say thank you very much to our chairperson, Dr. Najah Zayani, our keynote speaker, Professor Igor, and the rest of the speakers, and our excellent moderator, Dr. Sati, as well. The thing that I wanted to highlight after our evening tonight and the lectures and topics that we've heard about is, as Dr. Mu'min rightly mentioned, we wanted to identify, and as Dr. Najah mentioned in her introduction, where we can improve, where we can bring new things, where we can benefit our community and our population with services, with technologies, with advancements, with even skills. People who have been developing their techniques and capabilities for many, many years. How can we bring that to Bahrain, make it available to the local and regional populations? And this, I think, is definitely one of the areas where we feel like there are things that we can learn, things that we can develop and share with our people here in Bahrain and people in the region. And I would like to also echo how fortunate we are to have found these partners in Crystal Vision. As much as they said that it was a pleasure to work with us, I would like to echo that and say the same, that it's always been a focus on how can we do this in the right way? How can we do this in the way that's really going to benefit the people? What can we do to ensure that people know about our services and what we've done and what we can develop? And I'm very happy to see a wide selection of people from our community with us tonight. We're going to continue to have these interactions and work together to really see how we can benefit from these collaborations. If I may, before we break for a little bit of a dinner break, if I could please ask the speakers, the chairperson to the stage. We'd like to take a group photo, all of us together, to commemorate the evening. And then I'm sure during the rest of the evening there will be opportunity for the team to meet with you in person, answer your questions one-on-one. We will love to continue this collaborative and knowledge exchange evening. So Dr. Najah, Dr. Qasim, Mr. Onik, Mr. David, if you can join us on the stage along with the speakers and our moderator. And Bilal's here too. He can join us definitely. Thank you very much, everybody. With that, maybe I'll hand it off to Leslie to call the evening to an end and to invite you to dinner. Again, any additional questions, any additional interaction that you'd like to have with the team, please reach out at any time. We would love to hear from you. We'd love to know what you, or we'd love to hear about what you thought about the evening. I believe they have evaluation forms to fill in. We'd really appreciate if you could complete those and really give us a good reflection on how you perceive this evening. Thank you very much, everybody. I hand it off back to Leslie.
Thank you so much, Mr. Majid. Now, before we conclude, I am delighted to inform you that a gala dinner will be served shortly, providing an opportunity for further networking and camaraderie. I invite you all, and once again, I would like to thank everyone for your unwavering support and active participation. We hope you found today's program informative and valuable. This concludes our program, and I wish